Right now, we've got some situations that people don't find very tolerable. So, or where common sense squeaks around the margin of the rules. So everybody quickly adopted KRAS testing for certain tumors, because if you had a KRAS mutation, you couldn't respond to the drug. And the FDA said, well, we can't put that on the label because there's no prospective trial. They said that in December. I was in 07 or something, or 08. So the FDA said in December, we can't put it on the drug label because it's not prospective. And then 6 months later, they quietly put it on the drug label. But OIVD said we can't approve a regulatory test, a kit, unless there's a prospective trial. And there's still no kit today. So, you know, clinicians and insurers and doctors understood that KRAS was a highly effective test. And FDA has had a very hard time with it, or reverse themselves or pace around and stuff. And I think one of the things that happens, if you've got the KRAS mutation, you can't respond to certain cancer drugs. So even if you wanted to, nobody would ever get in a randomized controlled trial. If I had colon cancer today and I was KRAS mutated, I would never randomly get the trial. Or if I would respond based on a KRAS test, I would never be randomized to not get the right drug. Right? So you can't do the randomized trial anymore, which is one of the problems with the evidence hierarchy. And you know, people seem to know in practice that if the evidence is so strong from retrospective data that you couldn't do a prospective trial, then that should be enough, even if it's p.06, right, or p.07. But if it's not blatantly obvious, insurers find it very hard to go with. My example was FDA, but insurers are usually the same. I would offer two approaches that are frameworks for thinking about that, one of which I've actually already showed you. So first, you assume the system is rational as a starting point. So you would say, what I was showing you, what's the clinical question? What's the result of the test? What do you need to crosswalk between them? And then how do you show that? That's actually a framework. If the person's rational, they will believe your framework. The other thing, it's a slide I've used a lot of times. I didn't put it in today. It's treating it the claim as a value proposition. So if with the genomic health example, if your claim is I can accurately measure the levels of 21 genes, you can show that in a couple $1 million. But nobody would buy the thing based on the fact that you can accurately measure the levels of 21 genes. And if you show you can have improved 10 or 15-year outcomes, well, people would buy based on that, right? It's a slam dunk. It's too simple to talk about. But you can't possibly do that for 15 years. You can't possibly do that. So you have to find a claim that the person, like we can change the judgment for breast cancer treatment in 25% of patients. Like if that's the claim, that's your value proposition, what do you need to show that? Part of it's your RCT, retrospective RCT. Part of it's maybe a model. Maybe you want to add one more thing where you've done a real-world clinical study, to kind of back up the model and show it worked. But I think that the amount of data you need is based on what's your value proposition you're selling to the payer. And it gives you a way to think it through. It was actually, I came up with that in 2007 or 2008. Because people were saying, well, how much data do you need? We don't know how much data we need. Nobody can say. And well, this was at least a way of thinking about it.